All right, so fluid and electrolyte imbalances. Last lecture. With this one, there's another handout. It goes over the ADH stimulation of, your reabsorption, your angiotensin stuff. Yeah, and then it also goes over some of what the pressures are, and we'll touch on the background on both of those. But if you want some more detail, go look at the handouts, or maybe just before you study, give that a quick read. So what we're going to be doing is looking at fluid distribution, fluid imbalances, looking at edema, disorders of your thirst with your antidiuretic hormone, it's your ADH. That's what ADH stands for. And then we're going to look at electrolyte imbalances with hypovolemia, hypervolemia, and hyponatremia and hypernatremia. So it's a pretty quick one. Should get, barring any sidebars from the class, we should get out of here pretty quickly. Just everything, really. All right. So electrolyte imbalances. So we're getting away from heart and all that, right? So we've had 4 lectures on cardiovascular function. This is something completely different, for the most part. Obviously, with electrolytes, that's how your body regulates blood pressure to a certain degree, but that's something else, right? So we're going to be looking at, so to achieve homeostasis, the body must maintain strict control over water and electrolyte distribution, right? This is just like when you have, like the stuff that you learn in Intro to Bio, when you have like a certain concentrations of solutes and solvents, where the water will follow wherever the solute is, and if these solutes are proteins or enzymes or salts, that's where the water is going to go, right? And so the levels of the electrolytes in the blood compared to the tissues is going to be very important in regulation. This is why your body regulates that with your kidneys and stuff like that. So they become too low, too high, and then that's going to affect the amount of water in your body and in your bloodstream and in your tissues, and that's going to affect physiological function. So whenever your intracellular fluid is the volume of fluid within the cells, but the extracellular fluid is the volume right outside. This is going to be really important for when we talk about interstitial fluid, which is the extracellular fluid in between all the organs and stuff like that. So interstitial space, the intravascular compartment, the lymph, and the transcellular liquid. So most of the liquid in your body is within cells through and through, but a lot of it is also this interstitial fluid here. Now some of it's also just the blood of your plasma, and then other fluids like your brain, like the fluid around your brain, the fluid around your heart, that kind of stuff. That doesn't count in any of these. But the interstitial fluid is really important insofar. Do y'all know what that is? Interstitial fluid. Mm-hmm. So what is it?
I remember it. It's ISF, right?
Interstitial fluid, yeah.
I remember it's inside of the.
So. Well, so the interstitial fluid is what bathes like organs and cells. So like, so whenever like you're trying to get glucose to your organs, for example, the blood is going to leak out of the vasculature. Sorry. The blood cells themselves are going to stay in the vascular system, but the liquid component is going to leak out of the capillaries, and it's going to bathe those cells, and then all the sugar and nutrients are going to be absorbed by those cells from that fluid that's bathing them out of the vasculature. So when it's in between the cells and the vasculature, that is the interstitial fluid. All right, so that's what that is. So that's going to be really important for this lecture today. So the amount of sodium in the body is a prime determinant of the extracellular fluid volume. Sodium is the main cation, so that's important because we know that water is going to surround. There's going to be like I think it's 6 water molecules for every sodium molecule, right? So if you need a lot of water in your body and you have a lot of sodium, like that's a lot of the water in your body is going to be associated with that sodium. So if you eat a lot of salt, right? Like after these crawfish boils and stuff like that, that's what makes your hands puffy, because so much salt went into your body, and then all that water came in and surrounded all the salt, and it's going to stay in the tissues and blood and stuff like that. Right? Make sense? You made a confused face.
It just sounds disgusting.
Oh, it's just salt.
Yeah, but this slowly.
Oh, this is not the lecture for you then. Again, still not as bad as the STD lecture.
I can't wait for it.
I can. All right. So whenever you increase your dietary salt load, that increases the amount of solute and then increases the extracellular fluid. Yeah. So there's this whole drama with Starling forces. It's a complicated formula. You don't have to calculate this. It's looking at the differences between the cellular and interspace partial pressures and osmotic pressure potential. We're going to get the concept of this. We're not going to do any of the math.
So we can delete this slide.
Sure. Yeah, you can delete that slide. So this is the concept behind what that formula was saying, though. So the way this works, and this is hopefully a review of physiology class, I don't know, is that you have blood and plasma go through the capillaries, right? Capillaries are about 1 blood cell thick. And so what that means is you're squeezing all this volume that came from the bigger arteries upstream, right? You're narrowing the passageway a ton, right? This is like a 6-lane highway going to a 1-lane highway. You can't fit everything all flowing at the same rate, right? Things got to slow down, and it's going to build pressure there. So the blood's flowing into the capillary. Well, you can imagine that the volume is still really, really high, but the cross-sectional space is very, very low. Well, that's like trying to force, a gallon of water through a hose pipe. It's going to build up a whole bunch of pressure, right? And so that pressure that builds up, so you can kind of see on the left side of this graph, the maximal amount of pressure is at the very, very left end of the capillary as the blood's entering it. The pressure's so high that it squeezes out a whole bunch of the plasma of the blood. So what happens is that the plasma leaks out and it goes out of the capillary. But what that means is you've decreased some of the volume within the capillary cross-sectional area, so the pressure is going to go down. So what you can see is this linear decrease in pressure as blood is moving through the capillary bed, and that's because fluid is moving out of the blood vessel, the capillary, and into the tissues. You have a net fluid movement out. And so what you're doing is you're decreasing the amount of volume, and because of the amount of, it's like getting rid of some of the cars from the off-ramp on the interstate, even though the interstate's still only 1 lane, like going through this thing, right? So it's you're getting rid of some of the volume because it's going out into the tissues, and so the pressure goes downward.
So basically, as the fluid, as the fluid is being pushed out, the pressure decreases.
Yeah. And specifically, that is called hydrostatic pressure. So this is pressure from the hydro, from the water, right? So it's hydrostatic pressure is coming in and starting, and then it's pressing on this and forcing fluid out, right? And so once that fluid, that plasma portion of the blood, once that fluid goes out, and some proteins and sugars and salts, like it's not just water that's moving, it's all the stuff that's in blood as well. And all the immune stuff that we learned about, like all of that's going out into this stuff. So once it moves out of the plasma into the tissues, that is now in the interstitial space, and so it is now fluid that is in this interstitial space, which is the interstitial fluid. Now, what's great for this is that this is where your tissues lie, all your organs, all your muscles, and so this is how you get things like glucose and insulin and all the stuff you learn about. That's how you get all the nutrients onto this tissue. Now, the problem is that you just released a whole bunch of your fluid from your blood into the tissues. You need to get it back, right? Or you're not going to have, or you're going to be constantly depositing fluid into the tissues rather than having a liquid component of your blood. So the way that you get it back is that what you're doing is you got to look at the actual capillary again. So there's some proteins that cannot, they're too big to go into the interstitial space. So what there are, so just like the red blood cells, these larger proteins are trapped in the capillary itself. Well, the thing is that you've concentrated this fluid within the capillary so much that all of the proteins in the capillary bed no longer have the sufficient hydration shell that they need. Meaning, if, like, for example, you know how salt needs, like you may not know this or not, but like I think it needs 6 water molecules for every salt molecule to be dissolved. Mm-hmm. So like when you, so if you dump a whole bunch of salt in water, the salt's going to be released, and then 6 water molecules are going to associate with it. And so you need a minimum of like a 6-to-1 ratio of salt to like dissolve salt, or it just doesn't dissolve, even though it's fully soluble. Now it's not very much water, but it's like you need that.
That makes sense. So
now let's just pretend that like a protein was the same way and it needed 6 water molecules. Well, if you have, let's pretend like there's 10 proteins in the capillary bed. And so what that means is that you have 60 water molecules. Well, if you just forced out 40 of them, you know these proteins no longer have the amount of waters that they need to be dissolved. So, there's this weird thing in chemistry or physics that water will actually be dragged out of something to fulfill those hydration shells for those proteins, and it's something called a passive pressure. But what it is it's called or an osmotic pressure. You might have heard that term. So osmotic pressure is the pressure that is forced by the movement of water back in, and it's to surround something called a colloid. It's something that's dissolved in water, so they call it colloid osmotic pressure. So what that's going to do is that's going to take fluid out of the interstitial space and back into the capillary to fill the hydration shells of these proteins. Does that make sense? So all this to say is that you have really high blood pressure at the beginning of the capillary because of the hydrostatic pressure. Water starts to move out, the pressure goes down, 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 but then it goes too far, right? It's released too much pressure out into the interstitial space to where by the end of the capillary, some of the water is reabsorbed right there because of colloid osmotic pressure. That's the physiology background that you need. Have you all talked about this at all last semester? But it was a blur. So I think that's what all the words say. Oh, so that's not going to get all the fluid from this interstitial space, but that's what your lymphatic system's for, right? It picks up all the fluid, transfers it through muscle contraction, and then it deposits all the excess fluid above the heart back into the bloodstream. And so you get this really nice distribution of fluids between the lymphatics, the bloodstream, and the tissues. Make sense? So what edema is where you have a buildup of fluid in the tissues. So what that means is that something is wrong here. And there are different types of edema. Does not become evident until, doesn't become evident until there's a good chunk of fluid in there. So there's, what is this? Fluid imbalance. Oh, sure. So it may be localized, systematic, or dependent. So like it can build up in one area. So like when you break your arm, for example, and this swells up, This is a whole bunch of fluid coming there because it's trying to get a whole bunch of immune system stuff there because it feels like it needs to start the healing process and it needs to fight infections. But all that's fluid right there, and it's only on your arm where you broke it. You don't get a generalized inflammation there. But it can be systematic if you've got systematic problems with your lymphatic system, for example, or stuff like that. And then it can also be dependent upon things like gravity. This is a bad problem, right? You need to contract your muscles to move your lymph. And so like people who are sitting down literally like all day, they don't have enough muscle contraction to move the lymph back to like the against gravity. And so like fluid will just pool in their legs and they'll have like edema in their legs.
Would that be kind of like when you stand up too long and you get something?
Wait, say that again?
Would it be kind of like when you stand up for too long and you get or your feet start to swell?
Yeah, maybe, probably. Sounds about right. All right, so there's different grades about this stuff based off of how like resistant, how much fluid there is. You don't need to know like that picture though. And it can have clinical manifestations. You don't have the movement of fluids as it doesn't. The fluids don't move around as well, so wounds don't heal as much. Risk of soreness. They interfere with movement. Can be life-threatening because of you need a proper amount of liquid in your vasculature, right? So it's like you can be if it's all pooling in your tissues, then it can be a problem. You can have decreased blood pressure and not have the proper amount of blood pressure in your thing. Okay, so this is like what I want y'all to focus on though for this thing. So whenever you have edema, you've got a problem with that whole little TED talk I gave about pressure in your body, right? Either the pressure's not going out, or it's going out too fast, it's not coming back in at all, maybe the lymphatics isn't draining properly, and that's what we're going to talk about with these 4 different categories of what edema is. So the first one we're going to talk about is increased capillary permeability. So this is when you have capillary pores become enlarged, or the integrity of the capillary wall is damaged, and just everything leaks out. Does that make sense? Like there's almost no resistance, and this is so bad that those proteins that are even trapped in the plasma itself, like that drive the colloid osmotic pressure, those proteins even leak out. Well, what that means is you don't have any colloid osmotic pressure forcing them back in, right? And additionally, because those proteins are no longer in the blood, like all the water that was associated with them, like you know how we said like this 6-to-1 protein. If you got 10, then you got 60 waters. Well, those 20 waters, and then we said 40 went out into the interstitial space. Those 20 waters even are going to go out into the interstitial space that proteins go. So all the water that's associated with those proteins are also going to go into the fluid, and that's where you get really bad edema, right? Because of increased capillary permeability. Plasma proteins and other osmotically added particles, right, leak into the interstitial space and increasing the tissue colloid. So you have an increase in the tissue colloid osmotic pressure. So you're taking water out of the bloodstream and into the tissues themselves additionally. So you got like three kind of reasons why this is getting bad, right, and why fluid's building up. So potential causes of this is things like brain injury, allergic inflammation, immune responses, and malignancies. But that's the big thing that's causing that first problem. The second problem is decreased capillary osmotic pressure. Yeah, this is kind of sad. So what's going on here is that, right, you need those proteins in the blood to reabsorb all the water from the tissues, right? That colloid osmotic pressure. So the problem here is that if you don't have those proteins, then you're not going to have that colloid osmotic pressure reabsorb everything, and so fluid is going to stay in the tissues. Makes sense, right? But the question you kind of got to ask next is like, why would you not have any proteins in your blood? That's like a normal thing. So this happens a lot with does it say on the slide? Yeah. So if you're malnutrition and you're not getting the proper amount of amino acids, and the proper diversity of amino acids, right? What that means is you can't synthesize protein. So like we got 20 amino acids, for example, right? If you're missing one, and there's like a really important protein that needs that amino acid to be made, you're not going to make that protein because your protein synthesis is going to start, it's going to run into this amino acid, and it's going to stop, right? It's not going to make the full protein. Well, your body now doesn't have that protein, and if it's something really important like an enzyme associated with vitamin synthesis or like whatever it may be, what happens is you just don't have that protein in your body. And that's why malnutrition is so, you need to get your 20, or you need to get your essential amino acids at bare minimum in your diet. And so if you've got people that don't get proper nutrition, so you don't get these proteins made at all. And so your blood doesn't have the proteins in the blood because they're just not being made because you don't have the amino acids. Well, that's going to, your malnutrition is now affecting your colloid osmotic pressure, and you have the ability of liquid, and it mostly associates with the abdominal region. Separate story, but you get these like pot-bellied kids, where but that's all just fluid there. It's not like nutrition or fat deposits or anything like that.
So sad.
Yeah. So you also get swelling in the face, legs, and feet as well. Yeah, so that one kind of sucks. So increased loss of plasma proteins, losing kidney diseases. Yeah,
So
this.
decreased capillary and oncotic pressure, a sign would be more of the pot-belly.
Yeah, they typically have large abdomen. Maybe don't say potbelly. I don't know if that's politically correct or anything like that. I don't keep up with all that, but increased abdomen size. But you do have a generalized edema as well, because it's like all your tissues. It's just most evident in kids' bellies. This also happens a lot with burns. We're going to be talking about burns later, and this is like a thing that happens there. So that's another note to make. Okay, so the next one is, what do we got? Increased capillary hydrostatic pressure. So this is where you have a ton of pressure in the blood, and it's forcing a whole bunch of fluid out, right? So increased hydrostatic pressure. So probably the heart, the best example of this is venous obstruction, where you've like blocked some vein. So like imagine like you have a vein that branches into two, and then normally like the blood pressure upstream is like supposed to be divided by two whenever it splits. Well, then you cut off one of them. Well, all that blood is now being funneled into that one vein, and it's just a ton more blood pressure. Well, because you have a ton more blood pressure there, you have a whole bunch of hydrostatic pressure going into the capillary beds. And because you have increased hydrostatic pressure in the capillary beds, you then transport that fluid into that interstitial space, and you get swelling of things like this. And that's all that's saying. Yeah, typically a localized edema, but there is generalized edema. It generally results from increased vascular volume. Yeah, so this is what's happening whenever you have excessive salt intake. Whenever you go to these crawfish boils, all you're doing is you're increasing. What's going on there is you ate a whole bunch of salt that went into your bloodstream. Water then followed your salt into the bloodstream, and because so now you have a ton more water in your bloodstream. Well, because you put a whole bunch of volume in your bloodstream, it's only supposed to have a certain amount. You've increased that by a significant portion. So now you've got your entire vasculature now has more pressure, and that's why your blood pressure goes up after these crawfish boils, because you have increased amounts of volume, but your vasculature hasn't been able to expand to increase the volume. So you have generalized increased capillary hydrostatic pressure. That makes sense? Potential causes: heart failure, kidney disease is a big one here, premenstrual sodium retention, pregnancy, venous thrombosis.
Never mind.
Yeah, so that's what's going on there. And then the last one is venous obstruction. So it's wait, what? Hold on.
So that's the predictable stuff. Is that like the bloated lymph that you may have from PMS?
Possibly. Maybe, probably even.
And
I would
then
say.
the pregnancy would be like the third trimester swelling.
But that also might. I mean, there is a thickening of the endometrial lining there too, though. I think that's also a bloating contribution, because the endometrium thickens before it sheds, right? To make sure you always have an environment to support the growth of a human. So it might be that, but it might be this. There might be a contributing factor of edema as well. Okay, so what is this? Venous obstruction. So this is one of the types of increased hydrostatic pressures where there's an obstruction in the vein. This was I gave this example a little bit ago. There's obstruction in the vein, heart is still beating, builds up pressure in the artery. The fluid is still forced out because there's an obstruction and needs the increased resistance in the venous end, right? So this is I kind of already went over this. And it's all due to increased capillary hydrostatic pressure. Okay, so obstruction in the lymphatic flow. This is just, it's as simple as your hydrostatic pressure only rescues your colloid osmotic pressure only rescues I don't know, it's I think it's like 20-ish% around that area. So it's important enough, but your lymphatic system is absolutely critical in returning that volume to your bloodstream. And so if there's a blockage of the lymphatic system, or you're not getting proper flow through the lymphatic system because you're sitting, obviously this one's like a blockage because it would be both legs if it was like a sitting problem, and it also probably wouldn't be this bad. But if you have a blockage of the lymphatic flow, you're not going to drain your tissues as well, and then you get problems, right? So lymph. Now, what's great about this is that you can fix these issues. This is probably the easiest one to fix of all of them, but well, maybe not. Yeah, it depends on what the cause is. Yeah, no, forget I said that. But this can be caused by problems like tumors that grow. That if you have a tumor that grows outward, blocks the lymphatic tube, then it just you have a buildup of fluid. So obviously you got to go in and remove that tumor. Lymph is not being returned to circulation. Potential causes: malignant involvement of lymph structures, removal of lymph nodes of cancer or surgery, and infection and trauma involving lymphatic channels and lymph nodes. Yeah. So, so as far as assessment goes, you wear your compression socks. So you can do things like putting a wrapper or some compression on it, and then what you're doing is you're increasing the amount of, I guess it's not colloid osmotic pressure at that point, but you're almost applying like a hydrostatic pressure, like force back of the fluid back into your bloodstream, as well as providing resistance to the hydrostatic pressure as well. So like as much fluid doesn't leak out, and some more fluid goes back in, and over time you need a lot of circulation through the capillaries, but over time you can decrease that edema that way. Another thing is just inhibition of sodium reabsorption. Obviously, if you don't absorb the salt, you don't absorb the water associated with the salt, and you get reduced edema, generalized, right? This is like your crawfish boil one. So if you've got problems like the colloid osmotic pressure one with the malnutrition example, if you administer albumin, that's a great protein that can help get some fluids back into the bloodstream. Elastic support, stocking sleeves, elevation, so gravity, that'll help with your movement of your lymphatics, especially from your legs. But anything above your heart, it's going to flow back into your heart. That's why they say, like whenever you have swelling of something, they say raise it above your heart because you're just trying to get that lymphatic to drain back into your bloodstream there. But it's important that you like raise it above your heart. If you've got like a problem, like a broken ankle, and then you're resting it like this, you're not doing that much as far as reducing swelling. You want to get it like elevated. Even that's not enough, right? You want to get it elevated above your heart. So you probably want to like lay down on the couch and then get 2 or 3 pillows and then put it above there, so it'll drain a little bit better. Elevation of affected moderate to severe lymphedema can be created by light presses, massages. Yeah, you can massage the lymph back into circulation as well. There's like people who like specialize in this stuff.
Yeah, especially after surgery.
Yeah. Yep. Crazy. Okay. So, controlling blood osmolarity. Oh, right. So this is ADH here. So, so what's going on here is this is like a separate. So that was all the edema stuff. So now we're going to be talking about controlling blood osmolarity and looking at that regulation. So this is another part of your handout about how this works. So osmolarity is concentration of osmotically active particles. High osmolarity leads to if you have, that just means you're kind of dehydrated in that you don't have the ratio of water to solutes is off, so it's gonna increase your thirst, increase your water intake, as well as release this hormone called ADH. Do y'all know what that does? So
It's in the kidney.
yeah, ADH, well, it acts on the kidney. Yeah. Yeah, exactly. So what it does is it directs aquaporin channels, which are proteins that just move water, to where you reabsorb from the kidney the water. So you're reabsorbing water back into the bloodstream, so it doesn't get secreted through the urine. So yeah, it's a protein that reabsorbs water from. So what you're doing here is you're going upstream and downstream of where your water is retained. So you're increasing your water intake and increasing the reabsorption of water. And so you just need to regulate this, and this is how you could do that. I mean, this diagram probably isn't necessary, but yeah, that's all it's saying, right? And so of course there's a negative. Well, it's all the same stuff. This is like the word version. That's like the picture version. So and then obviously whenever you've hit that equilibrium of solutes to fluids, you turn off ADH and then you decrease your thirst again. So there's a negative feedback loop within the system. All right. So you've all heard of. Oh, this is a slide y'all need to edit. Delete this parentheses behind hypodipsia. It doesn't make any sense. I typed in polydipsia here. I meant to type in another word. This hypothalamus disorder, but just delete the parentheses. So.
Delete the whole thing.
Yeah. So polydipsia and hypodipsia, they're opposites. They're like opposite conditions. And so people with polydipsia obviously don't have hypodipsia because that'd be like.
Polyphagia is increased hunger, right?
Polydipsia,
the 3 polys.
Insipidus, yeah. So yeah, this polydipsia is you're drinking a lot, appropriate amount of thirst, symptomatic thirst due to water loss. So there's like levels where this is like normal and healthy, but whenever it gets off, there's and you have a compulsive amount to drink water, that can become problems. Have you ever heard the back in like 2008 or 9 or something? There's a contest called P for a Wii. This was like the Wii video game system was like big, and a radio host held a competition. Whoever like could pee the longest would win the Wii, like the video game. And so people were drinking like a ton of water, and then somebody died. Yeah, they had internal drowning, which sounds crazy. But yeah, But there's also people who just have mental problems that just like psychiatric disorders that do this as well. So that can be a major problem, but I mean, that's obviously extreme examples. And then hypodipsia is the opposite of this, right? Where you have decreased ability to sense thirst. So you are not drinking as much. This can become really problematic for places that are hot, and you become dehydrated, you pass out, heat stroke, stuff like that. So yeah, thirst is regulated by osmoreceptors in the hypothalamus, and this is actually where ADH is made. And so all this to say is that that whole entire regulatory system happens in the hypothalamus, and that's where what regulates thirst. So yeah, we talked about diabetes insipidus, not to be confused with diabetes mellitus, which is your metabolic insulin resistant stuff. This is just so your kidneys pass an abnormally large volume of urine that is insipid, so it's really dilute and odorless, and you have increased output, decreased urine output. So this is when you have a deficiency in ADH. So what you can imagine here is that even though your body needs water, ADH is not functioning properly. Well, so, but yeah, yes. So yeah, you're not depositing those aquaporins in the kidney, so you're not reabsorbing the water. So that means you're always getting rid of water, and that's why you have a dilute urine, right? You're always getting rid of the water in the kidney, but you're not reabsorbing it, even though your body needs it. So your body is like insensitive to ADH. In the same way that diabetes mellitus is insensitive to insulin, this is like insensitivity to ADH. Now, we'll talk about 4 examples here about different ways that can happen. But yeah, so you're constantly peeing even though you need the water, effectively, right? A problem with, but it could be a problem with the enzyme itself, the receptors, or the aquaporin proteins, as to far as why the ADH is not functioning as it should. And then you have polyuria, where you have large amounts of urine output. Right. So we're going to talk about these 4 different examples, and then this will like wrap up today. So neurogenic, nephrogenic, dyspogenic, and gestational diabetes insipidus. So the first one's neurogenic. So this is where you have a lack of ADH production in the hypothalamus. You might have also heard vasopressin. Have you all heard that? That is ADH. Like that is the same thing. So like whenever you drink alcohol, and you have to like go to the bathroom so much, alcohol is a vasopressin inhibitor to where it's not functioning correctly, and so you don't have any reabsorption, and that's why you become super dehydrated whenever you drink a lot, and that's why you're hungover the next morning is because it's just all hangovers are dehydration mostly. So that's why you just got to drink water and probably electrolytes to bring in some solutes to go along with that water, just so you absorb it a little bit better. But yeah, so that's what's going on. It's like a vasopressin inhibitor. So vasopressin is the same thing as ADH, if you've heard of that. Regardless, with neurogenic, you have a lack of ADH production in the hypothalamus. And what you can do is you can just take an ADH analog, get that back into the bloodstream, and then and you can get its effects still. So there's idiopathic versions of this, but then a lot of them are caused by things like head trauma. So you have trauma to the hypothalamus itself, and so it's not being regulated properly. The second one is nephrogenic diabetes insipidus, where you have the kidneys aren't responding to the ADH. This is like type 2 diabetes mellitus or whatever. So this is all that you have ADH being produced by the hypothalamus, being released into the bloodstream, but it's not acting on the kidneys as it should. And that is because you have a receptor for ADH, and it's called a V2 receptor, stands for vasopressin. The V stands for vasopressin. And I guess there's a V1 and a V2, and the V1 just at a different spot in the body, so don't get hung up on that. But it's a V2 receptor of the principal cells of the collecting duct, and this is where the aquaporins get inserted, to where because the receptor isn't binding the ADH, it's not signaling through this cyclic AMP intermediate to the vesicles to insert themselves on those principal cells of the collecting duct. And so because of that, you have that's why the ADH isn't working. There's also a genetic disposition to this stuff where you have a loss of the ADH receptor itself. All right. And then the third and fourth one is you have a defect in damage to the thirst mechanism in the hypothalamus. It's pretty simple. There's not a lot of science background here, where you ingest excessive amounts of fluid. There's also gestational versions of this because the placenta produces this enzyme called vasopressinase that destroys the vasopressin. And so you just got to treat with ADH analogs. But obviously, that's not going to work with this gestational because... Oh, really? That's interesting. Yeah, so if you administer ADH analogs with this, the vasopressinase is just going to kill it still. So you just need to... there's other ways around that. So we have this syndrome of inappropriate ADH, where the body retains water instead of excreting it in the urine. You have a failure of the negative feedback here, and you have delusional hypernatremia. Great. You gotta get going.
No, I'm not.
There's a noise. So with this, the treatments are going to be fluid restriction, diuretics, drugs to inhibit actions of ADH called Vactins.
So do we need to know the treatment? We need to know the treatment, but we don't need to know specific medication.
Yeah, you don't need to know, you don't need to know medications. Which I'm going to try to just go over less, but some of them are, I don't know, we'll deal with them as they come. All right, and then the last concept is sodium. How many more slides have we got left? Oh, a good bit. So we'll probably place this. So what I just want y'all to know here is, so normal levels are between 135 to 145 milliequivalents per liter of sodium. So if you get outside of that, that's going to be your hyper and hyponatremias. So what's important about this is that it is the ion of your body. So this is what regulates all of your electricity, all of your everything, right? So this is a very important thing to monitor for healthcare providers. And it regulates extracellular fluid volume as well. So it regulates blood pressure. It drives the sodium-potassium pump as well. There's a whole bunch of things that sodium does. Even the things you hear about calcium, that's upstream of all of your ion movements are always sodium. So it's really important. So if you have increased sodium levels, you do have increased blood pressure because of what we talked about before, and because of that increased osmotic pressure. And so you need a proper water and sodium balance because it's so important. And there's two main categories of these imbalances. We have isotonic contraction or expansion of the extracellular volume brought about by proportionate changes in sodium and water. So this is like the ratio of salt to water is the same, but you have too much water or too little water because these are tied together because of the hydration shells of sodium, right? And the second one is where you just don't have where the ratios are off. You have too much or too little sodium in your body, and that's hyponatremia and hypernatremia. So you can kind of go over this. It makes a lot of sense, right? If you just recognize those concepts where you have increased total body of water, right? So hypervolemia, you have a lot of everything's proportional, but you have a lot of volume, and you have excessive fluids. So a way to, so it results in weight gain because that's water weight. It's not like fat or anything, but a lower hematocrit because you've diluted the cells. Your plasma protein levels are diluted, distended blood vessels, and increased pressure in the capillaries. So all that makes sense. You also have hypovolemia, where you just have the opposite of all that. You have decreased blood pressure, decreased weight volume, and in severe cases, you've heard of hypovolemic shock. It's where you just don't have enough volume in your blood to supply all the organs and everything with blood, and so there's like a decreased thing. And then, see, we can just skip some of these. And then hypernatremia is just where you have too much salt. So this is going to make a lot of sense whenever, so maybe just give these a read. We've pretty much gone over all this already, but so it's which where you have too much salt in your, too concentrated salt in your blood, right?
So that would be
Hypernatremia.
too much of salt.
Yeah, yeah. So a lot of these symptoms. So what I want y'all to kind of, so a lot of these symptoms make sense that you're thirsty, right? You have dehydration. You just don't have the right amount of volume in your body of water. But what's important here is that we get water into your bloodstream. So it's going to be things like isotonic salt-free solutions. You don't want to apply like the saline bags because you'd be giving salt and water. That people already have enough salt. You just need the water. Yeah, so this is like dextrose and water because you want to keep the osmolarity the same. So you put dextrose in there, which isn't salt. Yeah, it's a type of sugar, yeah. But an innocuous sugar at that. It's not like glucose. And then you regulate until the ratios get back. And then the same is going to be true for hyponatremia, where you have too little salt. Well, this one you just put in a saline bag, right? You can also do a vasopressin receptor antagonist. And you stop the base, so you stop it vasopressin from working, meaning you excrete more volume, right? To try to restore those ratios. And this can happen from things like diarrhea, vomiting, diuretics, drinking too much water, stuff like that. But that's it for this. So yeah, just try to understand the difference between hypo and hypernatremia and volemia, and then just kind of how you fix those things. But just focus on what's bolded, and you'll be fine. Any questions there? All right, good. So that's it for today. I'll get this posted. So if you want to go over the tests at all, you can more than welcome to send me an email. But if you're not concerned about it, just focus on. Wait, what? Where are the YouTube videos?